more broadly in terms of any known specific interactions or clear contraindications for LDN? Is there a
I mean, the main thing is we always say long-acting opioids like MS-Contin, things like that.
So the big one is obviously all opioid drugs. There is a discussion about PRN dosing versus chronic dosing versus long-acting. We're seeing a lot more methadone patients show up for chronic use for pain control, not methadone maintenance program for opioid addiction. And so those patients are on a three time a day schedule, but that is a dramatic shift in their pain presentation as well as that blockade. And if we get the dose wrong with our LDN patient to those chronic opioids, you lose pain control for anywhere from 2 days to 5 days. And if you have a high-dose opioid patient who's chronic, then you could actually have something called narcotic collapse, which is its own serious life-threatening sort of scenario. So that's where we clear indication or contraindication. What we're also concerned about is this new sort of group of buprenorphine patients, because that is a wickedly powerful narcotic drug, and now we're starting to see it in some of these illicit drug utilization in recreational drugs of sufentanil and carfentanil. So we have to be aware that those drugs are out there, and so sometimes that questionnaire is like, hey, do you do party drugs? Because that can be pretty traumatic for these patients as well. So other contraindications, and it's funny because I always get this question as the pharmacist, hey, is this going to make me throw up if I'm drinking? No. It's just going to take away the next day. But you're still going to get drunk. You're just not going to be like, ooh, that was really fun. We should do that again. You're just going to be like, oh, that was okay. So there's no disulfiram-like reaction where you get nausea and vomiting and it doesn't rob the ability to drink. But what you will find out is you're just not going to want that third glass of wine the next time. So that's the interesting one. But you also see that with coffee.
But I have had a few patients. I have had a few very sensitive patients who did get sick. So I have this real conversation with them too when I'm starting LDN, because all of these things have happened. Patients literally, anytime you're starting a new medicine, you might not want to party on it, just in general. But so I always go with this. I'm like, please can you just see how the LDN is before you go out, and party. And I had a patient, like very first time taking LDN who like immediately like went out or like, drank and then took their LDN. Or I had another one, do shrooms and then take their LDN for the first time. And so I literally say, please don't drink, please don't do shrooms right when you're starting, LDN, because we want to assess that response, alone. So people, yes, can microdose psilocybin on LDN. They can drink on LDN. I don't do this personally, but I've had to talk to patients about these things, but I will say I have had patients that are really sensitive that have reacted to alcohol with LDN.
I've kind of got to go back to the disulfiram type response, which is like you're going to hospital and you're going into intensive care, like with even minimum doses of alcohol. This is a life-threatening scenario with disulfiram, whereas this is just like, oh, I feel barfy and you're puking. You survive that. It's just like a bad scenario. So slightly different. There was actually a couple of other drugs which we've seen. We actually see an improvement in a number of drugs and an improvement of response. So some of these more psychotropic drugs where people are getting like an exacerbation of those side effects, that's the other one, is like they're kind of like, woo. So you can get away with lower doses. So, and then the liver enzyme discussion, I do want to address that just one last time. It was not the LDN, or it wasn't the naltrexone, it was the abrupt cessation of drinking, and that has been widely discussed. And so that warning about, black box warning about liver enzymes, if you are a prescriber, cover your practice by having a liver enzyme panel that can be just a regular test. We don't expect it to change. What we have started to see, and this is like anecdotal, we've seen patients who have liver enzyme issues start LDN, and lo and behold, we see an improvement in their liver function and liver enzyme panel.